Thank you very much, Mr. Chairman. Assalamu alaikum wa rahmatullah. It's a good time actually to thank the organizing committee and also for their great job actually and for outstanding organization of this meeting. Although our society is so young, but Triple S meeting this year is really outstanding. The trauma around the craniocervical junction, challenges in diagnosis and treatment. We know that the craniocervical junction have a lot of challenges, and that because of their unique position as well as unique anatomy. The surrounding structure in the craniocervical junction is totally different and so critical if we look to the vascular as well as brainstem close to it. And even the visualization in the radiological investigation is sometimes so hard to go with only X-ray and to detect the abnormality, especially in the emergency situation. Look to this picture. This diagram is showing some of the ligaments, which is unique. You cannot find it anywhere in the spine, and this ligament is give you really a good stability during the movement of apical ligament, alar ligament, and transverse ligament. Each one of those small and tiny ligaments, it plays a very major role in our everyday movement of the cervical spine, as well as in keeping it actually in place. And this is the same from different view as well. Even the bony structure is different. Bony morphology is different. And the ligament is not, we're not talking about one per se is playing the major role. Actually, it's many apical, alar, transverse ligament. For example, if the transverse ligament is disrupted, we will get worried about the C1, C2 subluxation. And if the alar ligament or apical ligament is being disrupted, you get worried about the occipitocervical distraction. Let's start with the occipital condyle fracture. We know that the craniocervical junction, when we talk about craniocervical junction, we're talking about the occipital bone, we're talking about the occipital condyle as well as C1 and C2. Occipital condyle fracture, this is a rare fracture, and we can see it most of the time, incidentally with the patient with head injury, referred with head injury and all that stuff, then you can see the occipital condyle. And you can find it actually in literature, it's vary from 1%, some literature actually, they mention it actually reaching to 10%. But it depends actually on the referral center. In our center actually is around 1%. And most of the time they have cranial nerve injury, lower cranial nerve injury. And we usually don't pass it as a stable fracture, although most of them, they don't require surgical intervention. But now we will go through the classification, which is being endorsed by Anderson on 1988. And this classification, it make the diagnosis as well as the management plan is more easy. If you can see, he classified to 3 types. Type 1 is comminuted fracture without displacement or minimal displacement, and this is really is around like 20% of the type of fracture you have. Usually, this one it comes with the axial loading, and sometimes the ligament is being disrupted, although not all times. And type 2. In type 2, the linear fracture, which is extended from the skull base fracture, and that is really common and stable. Usually it doesn't involve any ligaments, and it is stable. It needs only just a collar, and it will do the job. The problem with type 3, when we have the effulgent fracture of the condyle, and this is if it is unstable if the ligament is being disrupted bilaterally, and most of the time you have it in unilateral position, but if you have it bilaterally, sometimes you need to interfere with C1, C2, with occipital-cervical fixation. So this is a diagram also just to show you the types, type 1 and type 2, type 3 as well. From Toronto, I have here guests from, we have here guests from Toronto as well. I think this paper is coming from them in 1997. It's being published in Neurosurgery Journal, and they have another classification for the condylar fracture, and they depend on the displacement. It is displaced or non-displaced, and they put it as type 1 and type 2. If it is undisplaced fracture, it is type 1, and it is a stable one. And if it is displaced, either A or B, if it is with ligamentous injury, that means type B, and it is unstable. The occipital cervical dislocation. This is the more challenging, and it's hardly to detect, in fact. Most of the time, actually, this can be missed, and the patient, if arrived, usually they die. The patient, they die in the scene, and we can see now with the development of radiological investigation and also the more awareness, we detect it more often now. You can see it actually in 1% from the patient who arrived to the ER, and 20 to 30% of direct death related to the cervical injury is coming from the occipital-cervical dislocation. This is being mentioned, is being described by Blackwood in 1908. As I mentioned before, it happened in severe injury. It have to be very high velocity injury, and usually patients, they die from the brainstem impact, and it's usually hard to detect in X-ray. Although there is some measurement, actually, it helps you in detecting the abnormality, but it's very difficult to diagnose. Most of the craniocervical abnormality is better to have more radiological investigation, I mean like CT scan and MRI. The classification for craniocervical dislocation, you can simply actually is being classified to 3 groups. Is like anterior displacement or anterior dislocation, or longitudinal dislocation, and posterior dislocation. And you can see it here in this picture. Is simply actually with the movement of the condyle related to the atlas. And if it moves forward, that means it is anterior dislocation, and vice versa. The power ratio, it helps you very much actually in detecting what type also of dislocation you have. For example, if we have the power ratio, the normal is 1, as we know. If for example, I find it above 1, that means we are talking about anterior dislocation. If it is below 1, that means posterior dislocation. Sometimes also in the posterior dislocation, if it is less than 1, you have to consider also a ring of C1, actually C1 fracture, like Jefferson fracture. This patient actually, he came to our center with referred from other hospital, and being considered as he have polytrauma, referred as normal cervical spine. Or craniocervical junction. and they refer him even in the ICU because he have spinous process fracture in the lower cervical spine. And the CT scan went down for him. Even the radiologist, he reported as normal. But our resident and fellow, actually, they detect this abnormality because this is the things which always we keep repeating, that looking from the CT scan and the screening of the patient in polytrauma, you have to consider craniocervical junction can happen and it easily can be missed. You can see here the anterior dislocation of the condyle over the atlas, and this is from this side, and if you look to the other side, it looked like a list displaced. So this patient he had a posterior occipital fusion. Another classification by Bilabara, and also it's been published in 2006 in neurosurgical spine. Also, they divide it actually to 3 groups as well, and that all depend on the MRI finding and the ligamentous injury. So they said MRI if it show craniocervical ligament injury, and the craniocervical alignment is within 2 millimeters of normal, less than 2 millimeters of cervical distraction, they will treat it with traction. This is type 1. And type 2, if the MRI show craniocervical ligament injury and the craniocervical alignment is within 2 millimeters of normal as well, and this is, the more than 2 millimeters of cervical distraction, they will treat it with traction. So the type 3, that's the one which sometimes they need surgical intervention. There is a condylar distance. Also, it can help us in detecting the abnormality in the X-ray as well as in the CT scan. Bang, he described it as if it is less than 4 millimeters, he found it in pediatric group. Usually it's normal if it is less than 4 millimeters. If it is above that range, I think is abnormal. Others are the focus on adult age group, and they mentioned if it is more than 2 millimeters is abnormal. You can see here, this is the condylar distance, and most of the patients are varied actually in their distance, but most of them you can see it actually in this actually they are very much, there is no much distance like bone on bone. But if there is a distance, we can consider it abnormal in adult age group if it is above 2. Also, we can look to the Harris roll of 12. If it is more than 12, this is suggest occipitocervical dislocation. There is another. We can talk now about C1 fracture. C1 fracture, as you know, is common actually, and it happens also with high velocity injury. Or most of the time is axial loading. The commonest type we can see is, or the commonest we hear about is the Jefferson fracture, where it is a 4-point fracture, and it's being classified as type 1, type 2, type 3. Type 2 is a Jefferson fracture, where he have 4-point fracture. If it is type 3, is only unilateral lateral mass fracture. This is like very much demonstrating the Jefferson fracture, and all of them actually. The challenge here is the diagnosis and the management is so totally different if you consider if the transverse ligament is involved or injured or not. This is another diagram just to demonstrate the type of fracture you have. Just to go quickly with C2 fracture also, as you know, we have the odontoid and we have also the hangman fracture, And the hangman fracture. Yeah, thank you. And the hangman fracture is the hangman fracture also can be treated either with C2 anteriorly, or you go with occipital-cervical fusion in some cases. This one patient, he have only C2 fracture, and most of the time they come intact. This patient, he is unfortunate. He have bilateral vertebral artery dissection and ended up with a stroke. And the management is varied. It starts from the collar, simple collar, to surgical intervention. Thank you very much for your time. And maybe the question